Good afternoon, everybody, and welcome. Thank you so much for being here. We're delighted that you've decided to join us for this session on Healthcare Advance Directives for Solo Learners. I think we have a slide here to share a little bit about what Learn is.
We do. Oops.
So Learn is a new nonprofit here in Idaho with a mission to provide quality community education on retirement and aging related topics in the areas of health, wealth, lifestyle, and caregiving. And this topic today definitely spans health and caregiving for sure. Learn is a membership organization comprised of professionals throughout Idaho who are committed to our mission and to improving the quality and access to this kind of education for free. And not only do they pay to be members, they also donate their time as educators to make this education possible. Learn is also a leaders network of the Society of Certified Senior Advisors. So about 25% of our members are certified senior advisors, and the Society of Certified Senior Advisors is a duly accredited organization that educates and certifies professionals who work with seniors, and they have sponsored us as an organization, even though not every member is a CSA, because they understand the importance of quality education for professionals and the community. As a disclaimer, just a reminder that while we are providing you this content, it needs to be considered general informational in purpose and is not to be considered direct or specific legal, financial, or health advice for you. We hope this education allows you to have better conversations, more educated and qualified conversations with your own legal, financial, healthcare, or other service provider. And we do ask you to consult with those people before taking personal action based on this information. As Dee said, my name is Dara Ray, and I'm the president of Learn. And I was able to bring together an amazing group of professionals to be on the board with me to launch this effort. I would like to thank today Dee Childers, who's our vice president and also sponsor for our first community education series. So thank you, Dee, for believing in Learn and what we're trying to accomplish with your heart, your soul, and your checkbook. Thank you very much. And I would like to introduce today Dee and Julie Robinson, both members of Learn. Dee Childers is the founder and care manager of Life Changes Elder Care Consulting, and Julie Robinson is the founder and care manager of Seasons Care Management. And I would like to welcome them both today to share with you.
Excellent. Thank you, Dara. And with that, I'm just going to ask all others besides presenters to mute themselves. We'll go through the presentation, and you're certainly welcome to type questions into the chat. And as we get towards the end of the presentation, then we'll take questions from there. I'm managing two presentations, two screens, and switching off with Julie, so I just don't think I can do one more thing at the same time. So we're going to do questions at the end. And with that, we are going to start our presentation. Planning ahead for solo agers. One of the things that we know is that there are a lot of us who do not have children or perhaps close family that we can depend on to be there to help us with our aging years. And so it's incumbent upon us to take some extra responsibility to make sure that we have thought through this process, documented the process, and have had conversations with people who might become our healthcare power of attorney agents. And so we are going to cover a number of things this morning. If I can make my
afternoon
presentation go. Why are we not? So we're there, and I should just be able to press down, and there we go. And now an end of life, there it is. So today we're going to talk about some of these topics. We are going to go through the basics of what is an advance directive, why planning is important, when we should do the planning, who should be involved, and why everyone over the age of 18 should complete this process. We're going to look at specific approaches for potential diseases. We might not have them now, but maybe we know we have a history of them in our family and things that we might want to do specifically relative to that. We're going to talk about do not resuscitate orders versus full code. And we're going to talk about some resources that are available to you as well. So with that, why advance planning? Well, we know that nearly half of all Americans die in a hospital. Nearly 70% die in a hospital, nursing home, or another type of long-term care facility, while at the same time, 7 out of 10 would prefer to die at home. So why is that? Only 25% of people die at home. 80% of patients with chronic disease say they want to avoid hospitalization and intensive care when they're dying, and yet only 20 to 30% of them have an advance directive or have talked to anybody about this and taken the actions that are necessary to prevent them going to the hospital and having intensive treatments when that's not what they want. And then even if they do have advance directives, 25% of the time, their physicians are unaware of their patients' preferences. So that's why we're doing it now. So with no advance directive, family members, friends, whoever that might be, how are they going to know what your wishes are? And how are they going to share those values and wishes with a practitioner? Who's going to be there to advocate for you, for your care, for your treatment, for your rehabilitation? Julie and I could tell you story after story about the number of times that the hospital was ready to discharge somebody to home when they really needed to be going to a rehab because they weren't able to even navigate the hallway with a straight line. Or I walked into a hospital room when the nurse was about to give my client 14 units of insulin when he wasn't a diabetic and he didn't take insulin. So having someone who knows you, knows your health, knows your wishes is really important when it gets to having an emergency. And emergencies don't only happen when we're old and have chronic conditions. I mean, COVID has been a great example of that. How many people I know have gone to the hospital room in intensive care and had no advance directive, have never anticipated needing this kind of service. And yet treatment, and probably aggressive treatment, was provided to all of them. So we know that there's a process that if there is no one that you've designated to be your healthcare representative, state law has a pecking order of who can step in for you. And we'll go through that in a little bit. I have come in to help people a number of times, as I'm sure Julie has as well, being the second to the bottom, any interested person. I have been able to come in and help people who needed someone to speak for them in their behalf. Without one, it could lead to family disagreements and conflict. Mom told me she always wanted to do this. Well, mom told me that. Well, mom told me this. And people do crazy things when there's a lot of emotion and there's money involved, and the court may have to get involved, could lead to a legal process. So this is without having anybody specified as your power of attorney. Then the only way anyone may be able to step in to help you is through another court process called guardianship. And Julie and I, while we both are actively involved in the Idaho Guardian and Fiduciary Association, and both have been or are guardians and conservators, it's not a process that you want to go through unless it's a very last resort. So bottom line, once you turn 18, you are legally an adult, and you are now in a position where, as a responsible adult, it's important for you to have an advance directive and to talk about this and to have conversations and choose people that you think will make decisions that best reflect your wishes.
And if I can just add a little bit, Dee, I mean, like it says there at the bottom, like once you turn 18, you're an adult. And like Dee said, we'll go through kind of the pecking order of who's in charge, but I've had instances on both sides, on my husband's side of the family and on my side of the family as well, where, you know, one was a heart attack that ended up in a life flight from McCall to Boise, and, you know, didn't have any power of attorney set in place. And so it was kind of, you know, and in his 40s. And so it was kind of a gathering of the family quickly to make decisions. And in his behalf, due to that heart attack, major heart attack, really died for a little while until the paramedics were able to bring him back. And then the other one, my nephew, only 20 years old, in a motorcycle, like dirt biking type accident. He was life flighted down to Boise as well, and had to have surgery and, things that people don't think about. A heart attack in your 40s, a younger person who's kind of still living that kind of crazy and carefree life sometimes, or even the simple things, driving down the road in a car accident. Regardless, either way, decisions needed to be made for somebody because of the situation they were in. So it's better to have somebody appointed instead of it, maybe being that family member that's the closest, or, the first one available, making decisions that you might not necessarily agree with.
Exactly. And here's a classic demonstration of exactly what words you choose may not exactly resonate in the same way with the person who hears them. So you could just be unplugged from a machine, although it might be a TV. Oops, there we go. Oh, I'm going to get here. I don't know why I'm having such a problem with this today. Technical difficulties. Now I can get here. There we go.
Okay. So advanced directives consist of two parts, which I'm hoping that a lot of you are aware of these already. So this is a refresher, or this is kind of fine tuning some of the things you already know. But your living will and your durable healthcare power of attorney. So these are what we're going to go into a little more in depth. So your living will describes your healthcare wishes for the end of life. So when you're not able to communicate them any longer. This, can be related to different diseases, and we'll kind of go into a little more disease-specific things for solo agers a little bit further on as well. So this can include your wishes for maintaining, withholding, or withdrawing life-sustaining treatment in a terminal medical condition. And terminal is the important part there. So that could be for artificial hydration or artificial nutrition if you want it or don't want it. And has limited application. So like I said, only when you have a terminal condition, an application for these life-sustaining procedures would only serve to artificially prolong your life. Death is imminent, or you're in a vegetative state where you're not able to communicate your wishes. So the durable power of attorney for healthcare specifies who you want to make decisions about your medical care, and someone who is going to represent your wishes and choices, not theirs. I did hospice for 5+ years, and a lot of times we had to actually kind of break it down for people and say, what would they want, not what do you want, because right now this is especially hard for you. So you have to step out of your own wishes and your desires to keep them alive as long as possible, even in this state that they're in. But if they were able to make a decision right now, what would they tell you? So that's super important, what your wishes will be and not theirs. They're only authorized to speak for you if you're unable to make your own medical decision. So just because you sign that piece of paper doesn't mean that they can turn around and make decisions for you. There has to be all of those medical things that happened before. So they may also be known as a healthcare proxy or agent or a healthcare surrogate. So you're naming someone, like I said, to make decisions if you can't make them for yourself. And it should include a HIPAA release that makes sure that they have access to your medical records. I do that quite a bit, especially if I'm getting to know somebody that wants me to be their healthcare power of attorney, or maybe I've been appointed as their legal guardian. I want to know more about them that can tell me what their wishes were, maybe when they were in a more cognitive state. And then you should also be naming an alternative person on your paperwork, preferably two. I've had instances where that first person in line says, I don't want to do it. Either I wasn't aware, or I'm not as comfortable as I thought I was going to be making decisions for them. And so that's why it's really important to have an alternate person on that list.
And I think, to Julie's point, we can't stress enough that making the choice of who's going to be your representative is so important, that they be able to make choices that you would want. And so you kind of have to ferret out that information in talking with them before asking them, is how do they feel about different things that you might choose for yourself. Julie and I both do healthcare power of attorney for people who have no one. And typically I don't make exceptions to that rule, except for a very close friend of mine whose sister I'm friends with, whose daughter I'm friends with, and we talk about these things together. But both of them have been very clear. They do not feel capable of making the kinds of decisions that their mother/sister would make. And so everybody's in agreement that I'm the one, because as we like to tease, I will pull the plug if that's what needs to happen, where neither one of them would be able to. So it's just, we can't stress enough how important that is to your choice, is that they will honor your wishes.
And I love examples of things that helps kind of put perspective for me. And we'll go into a little more depth about, if you've already done these documents, when should you review them? When should you, take another look if there might be changes that need to be made? But my mom had done her legal documents when I was probably about 12. And so she'd done them with my dad. And then she moved to Idaho probably about 10 years ago now. And a couple of years after she moved here, I said, hey, it's time for you to look at that and redo it. Because if I was 12 years old the last time you did this, and I was then in my, 30s, I'm sure that there are some changes. And what I specifically knew she had on there was she had put the oldest child as her healthcare power of attorney after my dad had died. And so I knew that my brother was still number one on that list. And there's also myself and my sister who were, I was at the bottom of the list because I'm the youngest. I don't know if I was even on there because I was so young, but I told her, I'm sorry, I don't think your son, my brother, can pull the plug if need be. And so I asked her to take a look at those. And I said, I don't care who you choose. I don't care if you choose, I'm not asking you to choose me, but I don't think he can do it. And so she agreed. And, we went ahead and redid all of her documents, with an attorney here to bring those up to date. And I feel better about that now, because I'm in healthcare, my sister's in healthcare, and we're both listed. But that's why it's so important that you're not just choosing the oldest child or the one that lives the closest to you. Or, as we'll get into, like, who do you choose if, you don't have those? And that's what this is about as well. So just a reminder, because I see a lot of people choose the oldest child so that they don't create fights or arguments.
I already moved to your next slide, Julie.
Yes. Okay. Sorry. Okay. So the advantage of doing it, you're in charge of it. You get to make that choice of who you want. Once you get to a guardianship, if there is nobody and it kind of becomes a family fight and there's nobody listed, then, you get that, maybe that other family member who becomes the guardian or professional guardian. And so you get that choice right now to choose who you want. But those documents can be changed or revoked at any time. Like we said, you can update them. For the healthcare power of attorney, you do not need a notary. Those are documents that, will go, there's, it says down here that you can find them, some free ones at honoringchoicesidaho.org. But some states require a notary. Idaho does not. not one of those. So kind of, you know, be aware if you move somewhere and redo it, what those states' requirements are. And again, they express your wishes. And then I've definitely used the honoringchoicesidaho.org for some of my healthcare POA clients that I have. It's very thorough. It goes into more questions, more personal questions to kind of explore what their wishes are. It's easy to do online, and then be able to save it as a PDF and then get it to those who need it as well. But each state, you know, can kind of tend to have some of their own documents, but they are recognized across state lines. Like for people that are moving into Idaho, or if you move to another state, they should be recognized across the state lines.
And so in addition to Honoring Choices website, we have downloaded all of those documents that are out there into the handout folder that you have been given a link to once you registered. So in addition to some other handouts that we've put out there, you can get all of the Honoring Choices. I believe that's from last week's session on the 8th. So if you go there, you can get all of the forms as well.
And there's a link to the handouts on the webinars page of our website if you're looking for it.
Thank you, Dara. And this is yours, Julie.
Okay. So what if you don't have these documents in place? What is the order, and who's going to make decisions for you? So if it comes to the point where, you know, there is the court process and you receive a legal guardian, that's the individual that will make those decisions for you. If there's not already a legal guardian, it's going to be who you've named as your durable power of attorney for healthcare. Your spouse would be, if you don't have the document, your spouse is going to be the first person that they look to, you know, pending that they have the cognitive ability. And then it goes down your children. So this is where problems can occur at times. You have, you know, 2 children, even more than one can cause problems. I've seen 2 children can, you know, have a lot of conflict. So hopefully if everybody agrees, everybody is happy and decisions are made in a timely and effective manner. But if not, then the next person down would be a parent of the patient. And then as we get even further down, a relative, you know, saying that they would be appropriate to, you know, act under the circumstances to make decisions. And then kind of when we're getting down to the bare bones, you know, a competent individual that, you know, says that they as well, you know, claim themselves to be responsible to help make healthcare decisions on your behalf. And then last but not least, I'm not sure, Dee, how many times you've seen something like this happen, but, you know, the physician can make decisions, and that's where you kind of end up bringing in the ethics board at the hospital and things like that as well too. So.
And to your point, Julie, the ethics board is always there in the event of any family conflict about which way to go, even when the documents have been clearly spelled out and you have a very vocal family member who opposes that. Sometimes assistance is needed in kind of navigating those waters, and the ethics board at the hospital is available to you at your request to step in and help navigate that and negotiate the appropriate path forward. So, whoops, now I'm too fast. I can do this. It's like if you have 2 screens, then you're just never quite sure which one I'm working on. So end of life care decision making, or, you know, we do unfortunately refer to this as end of life a lot, and we need to go through and change that, really, because it's not just end of life, as we've talked about earlier. Anytime you're in a health crisis and someone else needs to make decisions for you, some of the treatments that will come into play are artificial nutrition and hydration. And basically that means feeding you through a tube and hydrating you through a different tube, but that's an IV. Whether you want to have cardiopulmonary resuscitation, CPR, or you don't want that and you want to do not resuscitate. And unfortunately, we have so many medical shows on TV and in movies that make CPR always look like it's a some serious compressions or maybe a couple of zaps of the paddles on a chest, and the person comes back to life. And that's not always the way it goes. As we get older, as we have more chronic conditions, it becomes less and less viable that option is going to work and at least return you to a baseline condition if it's going to save your life at all. So we have to do more education around CPR as we age. And also then when we are talking at the later stages of life, regardless of your age, that a couple of services that are often misunderstood and misused are palliative care and hospice. And palliative care is very similar to hospice, except for with palliative care, you can continue to have therapies to help get you well again relative to the disease. So there's curative measures that can be administered. When you get to the stage with hospice, the difference is everybody's there to keep you comfortable, to take care of you, but curative measures are no longer reasonable and have been stopped. So you can't be getting chemotherapy and be on hospice. You can get chemotherapy and be on palliative care. So a few key terms that are helpful there. So on a living will, and one of the things that's just really important to understand is these documents, as they are typically written, are pretty limited in the amount of information that they're providing the medical staff about what you want and what you do not want. So right here, we're talking about all treatment. I want everything to be done to help restore my health and sustain my life, including I want artificial nutrition and hydration, and that no non-artificial services shall be withheld or withdrawn from me if I would likely die from malnutrition or dehydration. I want you to do everything for me. So that's one option. Another option has to do specifically with just hydration and nutrition. And so it gives you an option here that says basically, I would like it to be provided, or I only want one or the other to be provided, or I want both to be provided. So that gets more nuanced as we move through the living will part of the document.
Dee, could I ask a question on that?
You bet.
I always wonder, like, do they have a time frame, that someone could specify I'd be okay with this for 2 weeks or anything like that?
Absolutely. That's an excellent question. And yes, you can annotate those things on your document as well. There's usually, I've seen it where people have just written it in the blank space below where they pick what they want, that I want a trial of 2 weeks, or I want a trial of 2 months, or whatever that would be. And then if it's past that, I want you to cease administering it. There's other sections on the document where you can write it as well. So you can fill that in and be more particular there. I'll take nutrition for 2 weeks and hydration for 2 months. You can be as specific as you want. Okay. So the third option is comfort care. And basically this is saying that if we're unable to communicate any instructions and the application of artificial life-sustaining procedures will only serve to prolong our lives and the moment of death, there's no chance of coming back from this, that we can request that they be withheld or withdrawn and you allowed to die a natural death. So this is the first part is kind of a 2-section part. The last one is an alternative that just basically says that unless it's a possibility it's going to bring me back, then I just don't want you to do it. And so I think that brings us to the personal value statement, quality of life statement. So on the Honoring Choices Healthcare Power of Attorney form, which I love, up until this document, there really wasn't a section on the Idaho kind of standard form to articulate in a narrative what's important to you, what do you want to do, I call it a quality of life statement, and I've included in the handout material both a template as well as an example of a quality of life statement. And basically, it's another place that allows you to kind of share with your surrogate or your agent, what are the kinds of things that are important to you? What makes life bearable or worth living for you? And so, you know, for example, in mine, I know that I want to have sunlight. I want to be able to see nature. I want to preferably have my pets with me if at all possible. And I need music playing. And oh, by the way, I want it to be a playlist from the 80s. So that's going to help make my life of higher value. And so you can articulate that. I'm always working on my statement to kind of, as I think about it, it's like, well, I like waking up in a yellow room. So, you know, that's in my directive now. I prefer to be in a yellow bedroom.
And I would not. So therefore, you can see people are different. I'm about to paint my yellow bedroom.
This is a soft yellow, not a bright yellow, but yes, exactly. Julie and I need our own rooms.
So Dee, like, would you recommend that statement be something that is maybe attached to their living will, or there's something, a document that you give to your healthcare power of attorney? Like, what is your recommendation of where to put that?
Well, if it's a separate document, yes, I think you can put it with your living will. I think having all of these kind of documents closely related in a folder, but it doesn't need to be stapled to it. This is nothing that, I mean, you might pull it out at some point in time, depending on the kinds of things that you talk about in helping make healthcare decisions with a medical practitioner. But often this is going to be information that's more key to your healthcare power of attorney, your agent, than the medical profession. So if there's more medical related stuff, then I would have it attached to my healthcare power of attorney documents. Thank you, Julie. Okay.
So since I'm only working on one screen, I can see the chat box. And Charlie stated over here that her sister has made and put some directives in her living will that says, you know, about how much oxygen should be administered before they stop that. And then also not to discuss or talk about any changes in her directive. You know, if, you know, she happens to be under the influence of any medication. So I think that brings up a good point about, and I don't know if we have any slides in here on that, about when we do a little bit, but when you're making these decisions, yeah, I would not be asking somebody when they're heavily medicated on pain medications or things like that. So if somebody goes into the hospital and they don't have a living will, the hospital does like to get something put in place or get a healthcare power of attorney put in place. And so, yes, definitely looking at somebody's status, you know, under the influence of medications and not doing it at a time that they might not be as clear. So yes, thank you. I like that.
Great. So basically we're talking about, do they have the capacity, the legal capacity, the mental competency to make a decision, a change, and if they're coming out of a stupor, that's not going to fit that criteria. And we cover that just a little bit, but so yes, they have to be of a mindset that they can understand what it is that they're talking about, what the implications of that are, what the potential outcomes of that are. So yes, you have to be of sound mind.
Okay. So goals of care. So, you know, these are covered in the post document, which we'll get into here in just a little bit. And Dee's already talked a little bit about these in the living will document. So tube feeding, you know, feeding tube is placed in your nose or your mouth to deliver liquid nutrition when you can't swallow. It can also, as you get a little, that would be a temporary thing, but there's also, you can, you know, choose whether you have surgery to have a, you know, a feeding tube placed in your side. So a PEG tube, that's you know, another way of having a tube feeding is through your stomach. A ventilator is a breathing machine that, you know, attaches to your windpipes and helps you breathe when you can't. And we heard a lot about that due to COVID, people being intubated, you know, because their lungs were affected and their, you know, breathing difficulty. And so they were put on a ventilator. IV fluids, which you touched on a little bit. They're delivered via an IV in your arm, to keep you hydrated and get you rehydrated.
Well, and often medication is given to you through that IV as
True.
well, so.
Mhm. Dialysis, a machine that removes excess fluids and waste from your body when your kidneys are no longer able to. That can be done at a hospital. I've known, people, friends that have had, some type of machine that they hook up to at their home as well. So there's different options for that. And then blood products. So, that's why we all donate blood. And I keep getting emails that they're in, shortage of blood supply and please come donate. And I do that from time to time as well, as I think lots of people should if they can. But, given through a tube, replace your blood, for blood that you may have lost from, an injury or whatever too. So.
And this, in some ways, this sounds like a no-brainer, but we typically, as people, like to avoid things that we don't want to think about. And I think about one of my early DPOA clients and starting to have these conversations with him about what kind of treatments he would like or would not like. And basically he told me, well, if it'll keep me alive and I'll be doing well, then fine, I'd like to have it. And I said, well, how do you feel about a feeding tube? And he got this shocked look on his face. And he said, what do you mean a feeding tube? And I said, well, you have a lot of gastrointestinal issues. And so the possibility that your whole gastric system doesn't work well could be a potential, and you might need a feeding tube. How would you feel about permanently, not just temporarily, but permanently living with a feeding tube? And it really kind of took him back, and he had to think about that for a while. So we do need to pay attention. Some things we were willing to do temporary, other things we might not. And so then it's figuring out what temporary looks like. Okay, I clicked on the wrong screen again. There we go. Oops.
Oh, that's small. Okay.
That's why I did the one before with the feeding tube.
Okay.
This is really just the form here. And whoops, and looking at all treatments or only certain treatments.
Yeah, so it covers the same thing. So this is did you pull this from a Living Will document, Dee?
Yeah.
Okay, so yeah, it gives you the option, down here kind of at the bottom where it says only IV fluids, only tube feeding, both IV fluids and tube feeding. So like you said, it gives you different options that you can choose, one, none, both. So that's what's good, is that there's different options that you can choose. And then CPR. I think people, like Dee said, sometimes, you see those things on the hospital and they seem quick and painless, but I've definitely had older clients who have had CPR, and they definitely broke ribs. There's definitely, like, the sternum area was sore for weeks and weeks and weeks. And so it's important to look at what your overall health status is. If you don't have a lot of extra health issues, then doing CPR may definitely kind of bring you back as close to baseline as you were before. But if you're somebody who has a lot of chronic diseases, a lot of health issues, you're not going to be brought back to the same state that you that you were before this happened, because it's trying to restore your heartbeat. They're doing the chest compressions. They're, forcing all of these things to bring you back. So that's definitely something to consider, is all of your health conditions when you're making this decision.
And so on this form, so in the Idaho previous healthcare power of attorney form, it didn't even ask this. And this one does. And this portion on the healthcare power of attorney living will documents only applies in the hospital. It does not suffice if you are not in a hospital, and that's what we're going to talk about next. and that has to do with the post. Want me to do this one, Julie?
No, I'm good. Sorry,
Okay.
I was reading the comment in the side over here.
Oh, okay.
Just again saying that like sometimes it can be hard to get people to talk about their wishes because maybe they've had past experiences that are too close to home, and we never really know why they don't want to talk about it. Even when somebody, like, we would start a new client on hospice, sometimes they didn't even want to talk about these decisions and they were going on hospice. And I thought that was so strange. Like, you're going on hospice. Why? Like, we have to talk about this, so yeah, all range of reasons. But, some people like to have their way and they like to, that's one way, that Charlie said they were able to, get mom to actually fill out the paperwork, was to make sure that she got her way to the very end. So however you need to do it, sometimes is good. But the post, physician's order for scope of treatment, is, I would say, newer. I mean, but it's not that new anymore. They're working on that form to make it more uniform throughout, adopting a form that is kind of used more nationally, so that there's not so many different versions from state to state. But that form is specifically for resuscitate or do not resuscitate.
And so some states call it a POLST, P-O-L-S-T, or a MOLST, M-O-L-S-T, and Idaho decided to go with the post. So it's all the same thing, but different states have a form that says different things.
What slide number is that? Are you on, D?
This is 20.
Oh, okay. I kind of lost track of numbers because I can't see them. Okay, so let me minimize some stuff. Okay, so so the difference between the post and your living will is that the post has to be signed by the doctor. The purpose of it is to have the patient and the doctor talk about this, review it, discuss it, and then sign it, prior to emergency type of situations. Unfortunately, it's, maybe not over time, it's not been done quite like it should, but a doctor should never hand you the form and say, bring it back all filled out. They are to be discussing it with you in the doctor's appointment. And so making sure that there's time in that doctor's appointment to discuss it is important, because this is life or death that you're making decisions on. And it's not, a 20-year-old, healthy 20-year-old isn't going to be able to do a post. It's appropriate to do it when an individual, has an incurable disease or irreversible injury, an illness or a condition, that's progressing, getting worse. So for example, my mom with Parkinson's disease and diabetes, she's still cognitively there. She still lives on her own independently, but because she has a couple of health conditions that are continuing to progress, that post is important for her. And now that I'm thinking about it, I'm not sure if she has a post. So, but I do know her doctor. So I'll have to check with her, see if she has one. She has all the other documents though. Let's see.
Probably the bottom piece, which is that that document has to be readily available in order for it to be honored if it's a do not resuscitate. That nobody's going to take somebody's word for it. It doesn't matter if it's tattooed to your chest, if you have DNR jewelry. Right now, we don't know of any approved or authorized jewelry that meets that code. The only thing that's going to stop paramedics from resuscitating you if your heart stops and you're not breathing is a copy of the post that's been properly filled out. So it needs to be readily available, and this is what's going to govern the kind of treatment you're going to get both from the paramedics as well as the emergency department.
Is that kind of an old rule that put it on the refrigerator, or is that still in effect, ladies?
No, that's an excellent question, and I think it comes up a little later, but the refrigerator and the back of the front door are the two places that they will take time to look at for a copy of the post. So we'll show you in just a little bit a lot of the places, like, you know, I carried both my parents around with me in my purse. I made sure my sisters had them because they were both do not resuscitate in their aging and demented years. And I didn't want to, I wanted to make sure nobody did anything that was not in alignment with what they would want. So it's carried it in my purse the whole time. When it comes time for me to have one, you want to have it on you, but the paramedics aren't going to go looking for other than the back of the refrigerator or the back of the front door, the front of the refrigerator or the back of the front door.
So for me, at least, Melissa, I've got, because I keep like in a little manila envelope and it says emergency documents. For clients of mine that live in their own homes, I've got their medication list in there, along with, you know, if they have a post, as well as my guardianship letters. So it's clearly marked on their fridge.
Great question. Thank you, Lisa. So this is just quickly a look at part of the post form. They're not easy to come by. The state does not want those of us that are not in the business of completing them, physicians, emergency rooms, and or hospice companies. So you won't just be able to go out to the web and find one easily. You can find one that says something similar, but you do need to be with your doctor's office to fill it out. So the first section A is really about resuscitation, whether you should be resuscitated or not. Whoops. And
I'd like to point out there in section A that it says the patient does not have a pulse or is not breathing. So, you know, caregiver comes into the house, they're not breathing, they call 911. You know, that's the directive right there.
right. So section B is really about medical interventions and the degree of, if they do have a pulse and or are breathing, what kind of treatment do they want? What kind of measures do they want? Do they want just comfort measures? Treat them with dignity and respect, make sure that they are free of pain, that they're comfortable and taken care of, they're clean, that their wounds are managed, and that you know, if oxygen is used, it's used for suction to, you know, treat an obstructed airway, that kind of thing. They prefer to stay where they're at. So they don't want to go to the hospital. And if that's what it says, and too often that happens, and I'm kind of curious about the EMTs and decisions that they need to transport when people have comfort measures only. Versus limit additional interventions. So they may want to go to the hospital if it was indicated, but they want just kind of limited interventions. They do not want to go to intensive care, versus the last one, which is, yep, give it all to me. My mom was like that. She wanted everything. She was not prepared and didn't really want to die. And so that's what she wanted to happen if that's how it came down. And then here's another place that you can put those kind of instructions, you know, for periods of time or anything else that seems to fit this topic. And then section C, and I'll be interested to see if this continues to be on the post, because from my perspective, and I think Julie, sometimes it can be a little bit contentious with us. This is talking about other treatments and whether they're a yes or a no. And I don't find them always to be as simple as that. If you put on here that there is no IV fluids, no antibiotics, and what you have as an elderly person with a UTI, a urinary tract infection, and they're dehydrated, and that's all it will take to return them to baseline condition, I don't want them to not give them that. I mean, I've literally withheld giving somebody a post because the hospital didn't have it. when my own father was just dehydrated. And I thought, if I give him this, they're not going to give him fluids. So no. So I have worked with a number of senior doctors, geriatricians, and others to include instructions that say no, unless we'll return to baseline condition. And so that's some of the verbiage down here kind of speaks to that, but you have to think about other situations besides that are not just a flat yes or no. So a consideration to be made. And so the bottom, basically just asking if you have any of the other advanced directives. In our last session on this, Rick Bassett from St. Luke said, well, a post is not an advanced directive. It's part of the advanced care planning. And that might be just cutting hairs just a little too thin for me. They go together, but here's a place. Do you have these other documents, a durable power of attorney for finances, or a general durable power of attorney, one for healthcare or not? And then a place for the signature of the patient, or a surrogate, so like a guardian or a power of attorney could sign this document for someone if they did not have the capacity to sign it themselves, as well as the physician. And the basis for the orders, and that's the general gist of what that form looks like. And then there is another part to this that says doctors have been asked to send this information to the repository of this type of information, which is currently with the Secretary of State, is allegedly being moved to the Department of Health and Welfare. I think they need money for it, but the intent is that there is a central repository for this information. Now, and include your healthcare power of attorney document and living will. So not just the post, all three pieces. And that you can send these into, you fill out a short little form, send it to the Secretary of State. They'll scan it, put it in their system, and send you back a nifty little card that says, here's the password for, here's the username for this person, here's the password to get in. And so if you just carry that card with you in your wallet and something happens, they can see that card, they will know how to go get your directives from the Secretary of State's website. And quite clever. And I look forward to the day when we're fully utilizing it and the paramedics know about it and the emergency department know about it and actually take advantage of it, because it doesn't really happen that much right now. Have you had any different experience with that, Julie?
No, I think you're right in the sense of, I mean, first they're going to ask if it's easily readily available, from myself, or, but I don't know how much they go to that website. They, dig around in their wallet to see if they have a card. I remember before that there was the Comfort One, and you could wear a necklace or a bracelet that says "Do not resuscitate." My sister's mother-in-law had that and made sure she wore that necklace all the time because she did not want to be resuscitated. So I kind of liked that little bit of jewelry if they wanted to wear it.
Well, and I think I have several clients who carry the card. I carry the card, and my family carries the card. Part of that is because then, as a family member, you can pull it out of their wallet. So it's informing the family, the healthcare power of attorney, that the card exists so that they can get to it in case of emergency, and remind the healthcare providers in the ED, the emergency department, that there is something there and there's access to documentation.
Thank you, Dara. All right, so just a quick summary of the difference between the advanced care planning documents, which is the living will and durable power of attorney, are typically all one document, designated for everybody over the age of 18, has three key pieces. Actually, I might say two. It's the durable power of attorney and the living will, are what most of them have. This honoring choices one does have a place for personal value statement, which helps direct the goals of care, and can be completed with or without their provider. It's always helpful to discuss it with your medical provider. But it will be used in hospitals, critical care facilities, assisted living, hospice, whoever is providing you medical services. Versus the post is really designated for those who have a serious illness or life-limiting condition, and sometimes that's age. So it's recognized throughout the healthcare continuum. It's active and in force as soon as the document is signed by both the person and the doctor, or and I need to change my wording for that, the provider. So nurse practitioners, physician's assistants can both sign those documents as well. It does not have to be an MD or a DO. It can be some of the other providers that we have now. It is protected in a legally enforced statute, though I will tell you there's minimal penalty if the paramedics do CPR and you didn't want them to. And by law, they must do CPR if you're not breathing and your heart's not beating unless you have a post. So they don't have a choice in this matter. Doesn't matter if there's 20 family members standing around and say he has a do not resuscitate. Unless you can produce this form, it doesn't count. And the EMS, the emergency medical service personnel will comply with this DNR.
And as a side note, I had a client who had a post, but they did it prior to me coming on, but it was not signed by the doctor. And it was on their fridge, and the paramedics came and said, we can't follow this at all because it isn't actually signed by the doctor. So yeah, make sure that that signature is on there as well, so that somebody just hasn't, like the doctor hasn't sent them out the door with it to fill out and told them to come back with it, and they never came back with it. So so we had a question over here from Dwight. So if the post is used, if you are seriously ill, do you complete the post form once you are in that condition?
Well, unless your serious life condition is age, you're in your late 70s, 80s, when you're diagnosed, you're probably going to complete it when you've been diagnosed with that condition. So if you have cancer that's been diagnosed and you find that it's metastasized to the rest of your body, that is when you would do it, because you didn't know before then that this was something that was important to you. Does that answer your question, Dwight?
Trying to get off mute. Sorry. Yes, it does. Thank you.
You bet. Any other questions about these? All right, let's talk about what we do with it when it's time. Julie, what do we do with these things?
Okay, so we talked a little bit about, you give it to your healthcare agent. So whoever you've chosen to be your healthcare power of attorney and alternate, make sure they have it, they're aware of it, so they're not called out of the blue and suddenly told they're your agent. And they didn't know you chose them to be your agent, your primary care physician, and your local hospitals. If you tend to be a person who likes St. Luke's, still send it to St. Al's. All of my new healthcare power of attorney individuals I work with, we send it to both hospitals as well. And then, like Dee said, keep a copy on your refrigerator, back of the front door, copy with you.
And part of the reason for the two hospital thing is they both have some specialties. So it doesn't matter if you prefer to go to St. Luke's. If you're a trauma case, they're going to take you to Al's. If you're a cardiac case, they're probably going to take you to Luke's. So it doesn't matter what your preference is. They're going to go where their trauma center is for what your condition is. So that's why both need to have it.
Yeah, or sometimes they just take you to whichever one is the closest. If there's, I've had clients where I've said they're a veteran, take them to the VA, make sure they go there. But if it's something that is like critical and you're out in Eagle, they're going to run you to the St. Al's Eagle one. So.
Oops, skipped one, Julie. Forgive me. Okay, here I'm doing one of those things again. Okay.
So one thing I think people don't really kind of think about and consider, if you have a specific disease that you've been diagnosed with, what are some things to consider as that disease progresses? And so Parkinson's disease, that's something that your handwriting changes. I can already see my mom just in the year and a half she's been diagnosed, her handwriting is not what it was from the Parkinson's. And so, your signature is going to change. And so maybe you sign something, for the bank, you're not there at the bank, but something is signed and they look at what your signature was when you opened the account and what it is now. And, maybe they're going to deny something. So kind of as those changes come along, I'm looking at having a notary, to be able to document, this is your, the signature as of, April 13th, 2021. So looking at kind of updating that so it's not considered, not to be a correct signature. So Lou Gehrig's disease, ALS, talking about beforehand, just with the disease process of ALS, whether you would want a trach and be put on ventilation, if you'd want a feeding tube, things that are common as individuals progress with that disease. Dementia, what happens if you stop eating or drinking? I've had, a spouse who is so very heartbroken, and they're trying to spoon feed the other spouse, and their mouth is clamped and they're turning their head, and you have the other spouse that's trying to practically, it's so heartbroken, is trying to shove food, down their throat to keep them alive and going. So making sure that those things are documented. If I happen to get dementia down the road, this is what I would or wouldn't want in those instances. And I see that actually quite a bit. And then also, are there certain medications you would want to be stopped? I mean, we look at those type of things like, okay, their dementia is so very, it's very far along. They're in advanced dementia. Should they still be taking a cholesterol medication? These things that are continuing to prolong their life and prevent them from other things. So don't be afraid to get specific in these documents as well, especially if you have a, something a little more critical health condition. Mental health. So, I have a mental health client who, when I started with him, said, I never want shock treatment. I don't ever want that. And I said, don't worry. I, no fear on that one. But those are things, you can detail preferred medications that you want or don't want, any treatment modalities that you want or don't want considered as well. So those are important, for some mental health type of things.
Well, and specifically, unfortunately, we know that with the progression of dementia, sometimes that people's behavior and actions can become very out of control because the brain is just not functioning appropriately. And no matter how hard we try to get medications regulated into a point where they're balanced and a person can stay in their home, that not uncommonly, we're told that unless you can get this fixed in the next 3 days, you're going to be out of here. And then who wants to take you when you have behaviors? And so we cannot send someone to a mental health facility for even a week if you don't have this mental health provision in your advance directive. And they don't come in the honoring choices package or any other standard healthcare directive that I've seen. So this is one of those unique pieces where to find the verbiage that goes with it and have it as an addendum can be very helpful, or to have an attorney draw up one of these documents with the mental health directive included in it. I mean, we have some that even say that your healthcare power of attorney is going to be the one you trust to tell you it's time to stop driving, and you've signed that document. So there's other things that can be added to the advanced directive component of it, but I do find that psychiatric mental health piece to be very helpful. If you need to be taken into the hospital based on a psychiatric condition, the cops won't take you unless we have a document that says just this, that there's a mental health provision in there, and they're always surprised. So that's just an important thing to know.
And another thing, kind of goes along with dementia or any of these other type of diseases as well, too, is there can become fights over, actually, just started a case where family had, their family member do the healthcare power of attorney and financial power of attorney paperwork. But there is a question about whether this individual was actually cognitive enough to have done this legal document. So it's come into question, and I'm sure it will probably, if it's contested, about, because I'm in there as the professional guardian, and the family in question is the one that did the power of attorney paperwork after the diagnosis of dementia. So I think it would be good to have also some documentation that by your, whether it's a neurologist, if you say you have Parkinson's disease or something like that, your primary care doctor that says, you've been evaluated and, as of this date, you are of sound mind to, do legal documents, things like that. Because I see so many court cases where people have had, mom or dad sign paperwork, and then it goes into the court system and is contested, and lots and lots and lots of money are spent on attorneys to say, nope, I don't, they had this diagnosis at this date. I don't think they were cognitive. They shouldn't have done this or shouldn't have done that. And now so-and-so has gone and sold their house because they're the power of attorney, and it just turned into a huge mess. So I think it is smart, if it warrants it, to have some type of documentation for that.
So in the handout section, in the link that you were given, there are some documentation, a couple different ones relative to dementia, ones that you could look at and review and see if they fit for you. I think I put a copy of a mental health kind of paragraph out there that could be added to an advance directive. And so we've tried to give you a few suggestions of things to consider.
Okay, so definitely if you're assigning somebody, whether it's a family member, whether it's a professional because you are a solo ager, or maybe you work with solo agers, I'm guessing maybe in Lisa's case, you work with a lot of solo agers, when they are trying to decide on who would be most appropriate for their healthcare power of attorney, going through and, reviewing these things, what, better quality of life to you. So those, those items in the advance directive, hydration, nutrition, when you'd want it, when you wouldn't want it. And then, what are your values? Because it's your healthcare directive, but I think so many times, you get those kind of legal things checked off and those boxes checked off on the paperwork. But, as a professional, performing that healthcare power of attorney role for somebody, I want to know what their values are, what is most important to them. I want to be able to have those conversations and be able to pass that along, under the life story area, pass that along to the caregivers that are caring for them, in their own home or in some other type of community. The more you know about the person, the more, they don't look like that 85-year-old that walks with a walker. They look like that man who served in the military, had, a wife that passed away 10 years ago. And, he did all these great, things in the community for the community, whatever it may be, great or not, the more real they are to the people caring for them, I always feel like the better care they're going to get. So gives that helpful information, provide direction. My thing, foods, likes and dislikes. If you try and crush up my meds and put it in applesauce, I'm going to spit it back at you. I'm not having a behavior, but I might gag if you actually give it to me. So that's my thing. Is
I
the
like
things
applesauce, so fine.
so Dee will be okay, but I'll be next to her spitting the food out, or the meds out, and then they'll be mad at me and they'll say I'm having a behavior and I'm refusing meds when I really gag on applesauce. So those things, sleeping habits, what side do they like to sleep on? Do they like lots of blankets? Do they like just a sheet? Music preferences. Dee's already said she wants 80s music playing, as she's lying there in bed. attention to hygiene, working with a client right now who I shaved him on Friday because he was going to go out to dinner with his wife. And I said, hey, can I shave you? Because those things aren't getting done as they should be until I can get a caregiver in there. So attention to those type of details too. Or for the ladies, I have a client who she has little whiskers and I always have to get after the facility to please shave her whiskers. She's not going anywhere, but please shave her whiskers out of dignity. Dress, how do you like to dress? Those type of things. Some older men still like their slacks. They don't want to be walking around in sweats. They like their slacks and their collared or button down shirts. And entertainment. If you were to make me listen to poetry, I'd probably get up and walk away. But I'll sit and listen to people sing or play the piano. So those are important things I think at quality of life that we don't always get those specific details that we should.
Yeah, one of our healthcare power of attorney clients that's coming on, we are just kind of starting through this process and understanding, and I would have never guessed this from her, but she likes old Westerns and only old Westerns. That's what she watches. She watches little TV, but if that's what it is, it's the Wild West and Bonanza. And I would have never known that had I not had that question for her. So it's documenting that kind of stuff as well. I mean, please do not put on any murder shows. I do not want any violence in what's on the TV for me. So a way to make sure that the people that might be around taking care of you know who you are as a person and what's important to you and what do you like and not like. All right, when to review. Well, kind of a little mnemonic here is anytime there's one of the big D's. So a decade birthday, a divorce, a death, a decline in your health, or just significant health changes, maybe a new diagnosis, are times that you need to just review what you've got. Does it still fit? Is there something that's different? Because if we're doing them at age 18, 19, or 20, in my dreams, but I can dream, it's going to be a whole lot different than what your wishes would be in your 70s, 80s, and 90s. And so it is going to change what you would want to happen. And to just review it regularly and to review it with your healthcare power of attorney agents. It needs to be just a normal part of conversation done periodically. Oops. So one of the other things that we often don't talk about is making funeral arrangements and wishes. Actually, normal families don't talk about this kind of stuff. We talk about it a lot in our family, and I think probably many of us who work in this business do have those kinds of conversations. So more recently, I've learned about being composted with a mushroom shroud, and I like that idea. I don't want to be put in a box. I get claustrophobic. Even after death, I know I'd be claustrophobic. I'd really rather not use all of the energy to have me cremated. So I would like to be shrouded. I love mushrooms and compacted back to the earth. So there's continue to be lots of options that are available out here, and they expand and evolve. And we've got a presentation just on this coming up in a few weeks where we're going to have Danette Arnson on to talk about some of the things around this topic. What kind of service would you like to have? Well, I don't want a service. I do not practice a traditional religious faith, kind of more Buddhist Quaker. I prefer to have a celebration of life. I'd like a big party because I love parties now, and I think everybody should have a party when I die, and then you can talk about me. What do you want done with the remains if you aren't composted? Culturally, we haven't talked about some of the cultural components here, which are another piece that we have to add to. What are some of the specifics that culturally you want? And there are cultures out there where they build like a big kind of rack on top of a boat, and they light you on fire from underneath, and then they send you out to sea. And that is how you end. Sometimes people want to have prepaid arrangements with a funeral home. You don't have to do that. You can have a document that just says, here's what I want. And then when it comes time for your funeral or for those things to take place, you can just pay for it then. So you don't have to do an insurance policy with it, but it is helpful to have your wishes documented and written out? Or do you have a life insurance policy that's specific for funeral arrangements? You want to make sure that people have access to that and know where it's at. And then any religious beliefs, cultural beliefs that will affect your wishes should be articulated and have conversations with the people that will be making these decisions. It was somebody recently, I think it was on Julie and I do an early stage Alzheimer's support group. And one of the members there had a family death, and absolutely everything was just documented in full form, including what music to be played and what kind of food they wanted served. And gosh, it just made it really easy for the family, maybe even having your obituary written, which, wow, that's another topic we have coming up too. We've got Diane Ronane's going to talk about how to write your own obituary. And with that, that is what we had to say today. We do have resources in the handout folder that I've mentioned. And what other questions are out there?
And Dara have a link too in the comment section, in the chat section.
Okay, great. Thank you. Probably Dara. Thank you, Dara.
I did. Yeah. Any other comments or questions for our distinguished panel of presenters? All right.
Well, that means we must have covered all that we needed to cover today. And I thank you very much for attending with us. Julie and I are readily available to help and answer questions at any point in time. We both love what we do, and we love working together. I find Julie to be an excellent partner. We have two separate companies, but it doesn't really matter with us. We work together very conjointly and staff cases together too when we need to. So either one of us would be happy to reach out or to help you if you reach out to us.
And I'll just say on behalf of Learn, thank you for joining us today. Please, if you got value from today's conversation, please share the information. Let people know the resources available. This recording will be posted in the next probably 3 to 5 days, and you can watch for it there, but the handouts are available right now. And we hope you will look to our curriculum and select some additional courses that might fit your personal needs or for someone you love. And so with that, I will say thank you to Dee and to Julie. Thank you so very much for presenting such great quality content. Again, Dee, thank you for sponsoring this first educational series and believing in Learn.